Hi everyone, my name is Cindy Chmielewski, and I've been living with multiple myeloma since 2008. I was diagnosed with multiple myeloma back in 2008, but I really think I first started experiencing symptoms of multiple myeloma back in 2006. In 2006, I was a fifth grade teacher. I was suffering from this excruciating back pain. It was so bad, there were days where I just couldn't crawl out of bed to get to work. When you have back pain, you see an orthopedic doctor, and I went to an orthopedic doctor at the time. And without doing any imaging, I was diagnosed with degenerative disc disease. And for 2 years, I was treated with pain medication and just physical therapy. And over those 2 years, my symptoms really weren't getting any better. They were getting worse over that time. Finally, I went to the orthopedic doctor in tears, telling the doctor I couldn't teach anymore. I couldn't stand long enough to be at the blackboard. I couldn't take my students outside for recess. And he said, "Oh, maybe I should do an x ray of your back." And this is after 2 years. And the x ray machine was in the next room. So I went to the next room and had an x ray. He came back puzzled because I had compression fractures throughout my back. In time, we realized that I had lost 3.5 inches in height over those 3 years. I was then taken to a hematologist because my blood counts were off, and that was the point the hematologist knew immediately from my blood work and my symptoms, the crab symptoms. I had anemia, I had bone involvement, those typical crab symptoms, that he made that diagnosis within days. And when I first heard, I was in shock because, I never, people don't put like back pain and a bad back with a blood cancer. Just couldn't relate those two things together. But then I was in denial. I'm thinking, if I never heard of multiple myeloma, how bad could it be? You hear about the pancreatic cancer and lung cancer. I didn't hear about myeloma. I found out I didn't hear about myeloma back in 2008 because people with myeloma didn't survive very long. So we're very fortunate now, with all the drugs that we have. Maybe people diagnosed with myeloma today can live the same lifespan as someone who is not diagnosed. So that really makes me happy because once that reality set in, I was very, very depressed. I was worried that I wouldn't be around to see those milestones that we all long to see. So now I'm using my teaching skills to help myeloma patients learn a little bit more about myeloma so they can engage in discussions with their doctors. And today with me, I have Dr. Caitlin Costello. Dr. Caitlin Costello is a hematologist-oncologist at an associate professor of medicine at the University of California, San Diego. And now I would like to introduce Dr. Landgren is a hematologist-oncologist with the University of Miami's Sylvester Comprehensive Care Center. And before we begin, just a little bit, when we're talking about this myeloma landscape, it really has changed over the last decade or almost 2 decades for both the clinicians, the researchers, the patients. I remember when I was diagnosed with myeloma back in 2008, there were very, very few treatment options. Most of the things available today were not available. And Dr. Costello, can you just describe very briefly for maybe those people tuning in for the first time or someone who's newly diagnosed, what multiple myeloma is and what are some of the signs and symptoms of multiple myeloma?
Sure. I think it is just so important, you're right, Cindy, to kind of do myeloma 101. I think patients really can advocate for themselves if they understand really the basics of the disease. So, multiple myeloma is technically a form of a cancer of a cell called a plasma cell. So, a plasma cell is one cell that is a kind of important part of your immune system. Now, your bone marrow is the factory of your body's blood and immune system. It lives inside all of your bones. It is an organ in and of itself. And the plasma cell is one of the parts of your immune system that lives inside of your bone marrow. And what happens, and we don't have a really great understanding about why this happens. We have some ideas, but some switch gets flipped to tell the normal cell, the normal plasma cell in your bone marrow, to go rogue. That's how I like to think of it. It goes rogue. And when it goes rogue, it starts copying itself. This is what cancer cells do. They clone themselves, they copy themselves. But when they do that, they don't work like they're supposed to either. So now you have these cancerous plasma cells that are not working the way they're supposed to as part of your immune system to fight the bad guys. And so these cancerous plasma cells start producing these abnormal proteins. Now, your body and your immune system and your plasma cells are supposed to produce a variety of different proteins or antibodies to fight the bad guys, flu, COVID, pneumonia, whatever it may be. But when that one plasma cell goes rogue, it starts copying itself. It starts prioritizing to make one form of those antibodies relative to all the rest of them. And it's those bad antibodies that are getting produced that find a way to kind of run around the body and wreak havoc a bit. And there's a variety of different ways that it can affect your body when you're diagnosed with myeloma. One of the most common ways that that can happen is that those antibodies or those abnormal proteins really tend to kind of have an interest in the bones, if you will. And there's a couple different ways it affects the bones. I like to think of it sometimes as like a little Pac-Man almost. It kind of sometimes takes little bites out of the bones, or sometimes can almost form little tumors within the bones. And that can hurt. It's a lot of patients who are first diagnosed with myeloma say, I have this pain that I don't know why it's there and it's not going away. And they seek care for that. And sometimes it can take a while to get to a diagnosis of multiple myeloma, but bone pain is a common presenting symptom. The other one I would say that's another common presentation or symptom is that, and this is hard because we're all tired, life is hard sometimes, but fatigue is real, and fatigue can happen because of anemia. I just said that, multiple myeloma is a problem in your bone marrow. Your bone marrow is your factory not only of your immune system, but also of your blood. And if your bone marrow is so busy making these bad cancerous cells, there's almost not enough room to make the normal blood that you need. And that kind of decreased production of your blood, known as anemia, can really produce symptoms of significant fatigue, shortness of breath, lightheadedness as examples. So those are some of the most common symptoms that patients come to get medical help for when they're first diagnosed with myeloma.
They were the two symptoms that brought me to the doctor. The first one was bone pain, basically back pain. I had terrible back pain and I was just so tired and out of breath. So, yeah, those were the two that got me there. Let's talk about treatments. In the last couple of years, I mean, we've had a slew of new treatments. Even just last month, we had two new treatments. When we are thinking about what treatments a person should be on, what are some considerations that you kind of weigh in your mind? I guess maybe we first could talk about, like, what do you think about if they're transplant eligible or ineligible, newly diagnosed versus relapsed refractory? Like, what are those considerations?
Well, I think that a big kind of step forward in the field has been the evolution of all the different options. So it's no longer, in my opinion, a matter of picking A or B. I think we have pretty much a whole alphabet to present. So there are very many options, and it starts in the newly diagnosed setting. There are a lot of options, and if someone has a recurrence, again, there are very many options. Looking at the guidelines that dictate what we're allowed to prescribe from a registrational perspective and also reimbursement perspective, the so-called NCCN guideline, there are over 40 different combinations that are in this guideline in the setting of relapse refractory disease. So when I have a newly diagnosed patient, if I'm thinking, is this person a potential candidate for transplant or not? I think that has also shifted over the years because we can technically transplant many more patients than we could before. We can transplant people that are older, and even if there are comorbidities, is possible. But on the flip side, I personally think that the need for transplant has probably gone down because there are so many new treatments.
So let's talk about this word cure. I know a few years ago, maybe about 7 or 8 years ago, when I was attending some of these scientific meetings, doctors were very hesitant to use the word cure. They were talking about controlling myeloma and keeping it, at bay for several years, but I never heard the word cure coming out of their mouths. But now, more recently, I am hearing the word cure, and that doctors are thinking that maybe we are curing some patients. We might not know who, and that there will be a cure for a group of patients in the future. So, can you talk a little bit about, are we heading towards a cure, and what do you think?
Of course, Cindy. I think this is the other C word, right? The big C we think about is cancer, but realistically, the big C, that cure word, is becoming something we're really starting to flirt with, as you say, over the last couple of years here, as we've seen, just like you said, just kind of this explosion of new medications that are out there. As you mentioned, in the last 2 decades or so, we have seen the amount of options for treatment go from nothing, essentially, a transplant, for example, to just this wide variety of options that are letting people get into remission and stay in remission for very durable, long periods of time. And now we're starting to see that happening for such long periods of time. We're saying, well, is it ever coming back? So I think we still have work to do to understand the difference between a long, durable remission, which means it goes away and stays away for some great period of time, versus a cure, which means it ain't ever coming back, which is what we're all aspiring to. And so I think we're getting there. I always tell my patients, in my lifetime, we're going to do this. We absolutely are going to do this. We've seen too much change in the last decade or 2 decades to not reach that point. But to answer your first question about, what are the right treatments, I would argue that this is not a one size fits all type of cancer. Although multiple myeloma is kind of grouped together as one kind of form of a blood cancer, there are very different subtypes and very different kind of forms of myeloma that will act differently. And some are kind of, let's say, easier to treat and make go away than others that can be a little bit more stubborn. So when we're thinking about what the ideal treatments are for any individual person, I think it has to be exactly that. We have to look at you as a person, you as in your health, you in your social situation, your support, for example. And then we have to look at the biology of the disease and kind of put all of that together to figure out what are the best means of achieving that cure that you're talking about.
I do think we are heading towards a cure. And I also want to point out and say the reason that the field has not talked about that topic in myeloma in the past, I think, is for multiple reasons. One is that, quite frankly, the drugs were not good enough. We used to have one or two drugs for many years, way before I started practicing. And then there was the emergence of high dose chemotherapy with melphalan, the so called transplant. Then there were the kind of the rediscovery of the IMiDs with Bordology's discovery from thalidomide, and then that led to lenalidomide and pomalidomide. We had the proteasome inhibitors coming just around those drugs were coming out, and then we have had all the immunotherapy. So the field has evolved, and I think we can see very many patients achieving remissions, and very many patients these days can also achieve MOD negativity. So there is no detectable disease. And I want to also lastly say that I have many patients in my clinic that are cured. And I have patients who have been off treatment for actually 20 years, and they remain off treatment doing very, very well.
Well, thanks for giving me hope that you think there'll be a cure in my lifetime. So that makes me smile.
So I think the takeaway message is that myeloma is, I do think, at the tipping point as a disease. I think if I put all my years of experience into perspective, it used to be a disease that was sort of almost like a kiss of death. And now it is a disease where the lifespan, I think, for many patients is getting very close to, if not identical to, the general population. We do not yet have a cure for the disease, but we can control the disease and we can provide very good quality of life for many, many patients with these drugs. So I think the bottom line of what I'm thinking and saying here is that seek advice by experts, and if you choose to be treated locally by a local doctor, the expert can always be looped in and give advice if there needs to be some changes and strategic kind of considerations. But involve an expert when you're newly diagnosed or if there are needs to make new decisions. So the future is very bright, and we are always here to help you.